All right.
Looks like David just joined or is joining.
See my screen okay, everyone?
Yes, we do.
Okay. This is an interesting patient, and you'll see why in a moment. It addresses the adage, sometimes that very uncommon things sometimes come in spurts. So here is a patient with a very extensive tumor. I do not have a contrast-enhanced CT, but starting up high, there is opacity here consistent with lymph node metastases from it, or lymph node metastases. You can see very extensive tumor in the chest. I'll scroll down to give you a feel for where the tumor is. There's a lot of abnormality in the right paratracheal mediastinum. When we get to the hilar region, you can see a very extensive tumor with associated airway narrowing and extensive tumor located within lung as well as extensive intrathoracic lymph node enlargement. This will give you a feel for the FDG avidity associated with the tumor. So here in the right supraclavicular region, extensive tumor. You can see extensive tumor in the right paratracheal mediastinum, more of the same, so very extensive tumor. When the patient presented clinically, she had face and neck swelling, and not surprisingly, you will see findings here of SVC obstruction, subsequently stented, as you can see there. So what's interesting about this patient is that a biopsy was done.
Howard, can I venture a guess, given your clue? Is this
which clue? The hint that I gave that.
The hint that rare things come in pairs or spurts.
Absolutely, go for it.
Is this going to be another midline nut?
Yep. Very good.
Still have never seen one of those myself.
Yep, here's another one. As you can see here, initially we look at this under the microscope, and they don't clearly diagnose a particular malignancy. Not surprisingly, the pathologist nowadays will do a whole spectrum of immunohistochemistry in an attempt to diagnose the tumor. As you can see here, I'll blow this up. They did a huge number of things. So some of these are for epithelial tumors, some for neuroendocrine tumors, and so on and so forth. You can see initially that they concluded that this is consistent with a poorly differentiated carcinoma. In terms of thymic origin, I don't think that this is typical for that because it doesn't appear centered in the thymus per se, but that was the initial diagnosis. And they started treatment for the thymic carcinoma, but they also sent tissue for additional genetic analysis. And one company that does this is called Foundation. And as you can see here, they found a very typical fusion anomaly between some chromosome or DNA on chromosome 15 versus 19, as you can see here. So this really clinches the diagnosis. And this is the typical genetic abnormality in this tumor. So that's exactly it. So this is a 52-year-old person, I think. Usually I think about this in pediatric patients, but this person is older than that, 52, as you can see there. So yep, another case of that tumor. Unfortunately, the prognosis is lousy, as you know. But this one is almost identical in terms of where the tumor is compared to the one I showed about 3 or 4 weeks ago. Virtually identical. It was right hilar, mediastinal, and also supraclavicular. So another case of that.
That's amazing. I still would never say that prospectively, but you know, I wish somebody would give us the clue that it's going to be a rare thing that we've just recently seen. So
yeah, exactly. Yeah. All right. Let me show you this case. I don't know for sure whether I showed this before at the webinar or whether I sent this out for an opinion. But these are two different patients. So I've got these labeled as example 1 and example 2, as you see there. The one that I sent out to you folks before involved this thing. So this thing was called as an intimal injury of the aorta, the medial aspect of the aorta. And subsequently, that was actually, to my surprise, stented. And I remember, Travis, you in particular suggested that you thought you could see that this thing here continued inferiorly and subtly and may represent a bronchial artery origin arising from that particular location. So when I saw this case the other day as not a case of trauma, but just as a CT case, let me not bring those together. So let me blow this one up. I saw this and it reminded me of that case. So here it is again, different patient, incidental finding. Here you can see the bronchial artery origin and you can see the bronchial artery coursing inferiorly. Here is the sagittal view, and let's see if I made a MIP. So a really nice example of a bronchial artery arising in that location, potentially responsible for a false call for an intimal injury like that. This shows it very nicely. It's exactly the same vessel. So I'm not sure if I've noticed that. Commonly, maybe I overlook that. I usually assume the bronchial arteries arise more inferiorly in relation to the aortic arch, but this is certainly one right there as an example of that anatomy.
That's a nice
I think
correlate.
Travis that quite commonly.
No, we don't see it that commonly, but
Okay.
Yeah, I'll see it more frequently now that you showed us a good example of it.
Yeah.
So Howard, was the first case a case of trauma that made you think strongly of aortic injury?
It was definitely a trauma case. You can see there's a lot of hematoma. I think there were lots of fractures. Definitely a trauma case on the previous occasion. And the reader called that without hesitation an acute intimal injury. And then for some reason, the surgeon put a stent in for that. Yep, on the previous occasion, the previous case for that thing. I would not have suggested a stent for that, but now I know what to look for. So that is interesting. Let me see if I have another one. I'm trying to remember. I showed some of these last time and I still have them there, so let me just see. I don't want to show the same case as I showed last time. Oh, this is an interesting case. So this is a case that Leif told me about. It's a really cute case. I don't have a chest radiograph, but here's the chest radiograph. And you can see, just looking at this, at the scout topogram, opacity in the basal hemithoraces. Here, you're facing the heart and the diaphragm looks odd. And here there's also opacity. So here's the corresponding CT. And it's a beautiful demonstration of foramen of Morgagni hernias, but it's bilateral. So let's go way anterior, and you can see it's a double-barreled one. There's a defect here, there's a defect there, and you can see fat and a portion of colon going through the defect, particularly on the left side. So unless you guys feel differently, I've labeled this as bilateral foramen of Morgagni hernias or double-barreled foramen of Morgagni hernias. Just a nice example of that. I think it's the first one I've seen that's bilateral, simultaneously bilateral.
Could it be one big defect that spans the midline, crosses from one side to the other? Is it two holes or just a big hole?
Yeah, let's have a look and see if it's just sort of equivalent to one big defect. Well, here, as we go a bit posterior, the diaphragms seem to be intact there. And then we have not intact, not intact. Yeah, perhaps it's all just one right across. Well, you know, you have a hemidiaphragm.
It looks like a smiley face right in the middle there, though, right on that image.
Sorry, Travis?
Yeah, right on that image. Doesn't it look like there's something central, that it is two separate Morgagni hernias?
I think so.
Can you see it on a sagittal? To see if
Yeah, it's got
the central tendon.
sagittal. Okay. So left side here. So let's go from lateral. Here's defect there.
Right.
And fat and colon coming through there. Then we get some diaphragm here.
Right there, there's a little.
Then we go over to the right side. Oh, sorry, this is the left side. So defect there.
So was that a little central tendon, as Jeff pointed out, centrally?
I think so. Intact here.
Mm-hmm. I think it's two of them.
That's really cool.
Is intact here? Okay, yeah.
Really
Because
neat.
it's intact at least at this level, right?
Mm-hmm. Yep.
Okay, just a cute incidental finding. And here is another one that's actually interesting. So I don't know the history in the presentation entirely. So this is the bottom of the chest on an abdominal CT. And the finding of note here is the calcification that we see a bit of in relation to the right heart. And that's an incidental finding as best I can tell. There's pleural fluid, but I don't know what else was potentially going on in the abdomen. I don't have a history. This is from the outside, I don't think. But here's the subsequent workup. So here are some images. There you can see the right atrial tumor. Now, I haven't looked at these in a while, but this is a right atrial myxoma. Here is some more images of it. Some more here. Let's have a look. There you go. So that's a right atrial myxoma. And oh, I do have some path. So the path did actually show that it does have some focal ossification going along with that calcium or bone that we see right there. So a nice case of right atrial myxoma removed with some ossification of it. All right, Jeff, those are my cases.
All righty. Thank you. Those were great. All right, David or Travis?
I have a couple.
All righty.
I got here late. I'm here.
Oh,
Hey, what's up?
well, let's
No,
let
no, I was just very late.
all right, we'll let David go, and then if you want to go next, Seth, that would be great.
Yeah, no, that's good.
So can people see a rentgenogram?
Yep.
Not to be confused with a radiograph. Okay, so this is a youngster, I think 16 years old, with this blob in his right apex and perhaps some rarefaction up there, and lateral view done backwards at this institution, not particularly revealing. Little pectus excavatum. And here's CT on this person, which shows a central mucus plug here, low attenuation, lower than muscle, and surrounding hyperinflation. So this is a congenital bronchial atresia on this person. Now there's a node calcification down here, but I'm not seeing any impact on the central airway. So bronchial atresia. And the coronal is dramatic, showing the mucus plugging, which is pretty extensive in this person, and the hyperlucency. So congenital bronchial atresia, we see it more often on the left than the right. You've even seen it a few cases in lower lobe. Our next case is a woman with Louis Dietz. I hope I'm pronouncing that correctly. So she's, before we got her, she'd already had aortic surgery. So this is post-operative aortic surgery for her Louis Dietz. What struck me about this case was the dramatic pectus carinatum. So we see a lot more excavatum than we do carinatum, but this is definitely a deformed sternum here. And I don't think it's because of heart disease. I've seen, sometimes the sternum bulges if the heart is large from congenital heart disease, but this heart is not congenitally large. It's not large even as an adult. So this is one of the lesions that can occur with Louis Dietz. And here it is here's a later chest radiograph on this person in the CT scan, which again shows this dramatic sternal deformity here. So pectus carinatum, not excavatum, really a pointed sort of thorax like this. And the sagittography here is dramatic too, in terms of this, the course of the sternum here bent around the heart like this. So dramatic pectus carinatum in this person. It turns out that is one of the associated lesions. Here's just the Wikipedia thing here, and they do talk about skeletal and spinal malformations, including sternal abnormalities, pectus excavatum, and pectus carinatum. So this is not unheard of in Louis Dietz. I've not seen very many of these cases. I think maybe 2 or 3 total.
Nice, yeah.
And then this is a woman who had some home remodeling done, and they busted up a tile floor that she had in her kitchen, and there was a lot of dust in her house, and she got short of breath around that time when she was having this remodeling done. And I think she's pretty elderly, maybe 82, 84, something like that, and was convinced that she had silicosis. So she called me as a B reader, and she called a whole bunch of people because she was convinced that she had silicosis. Her doctors eventually ordered a CT scan, but she has this abnormal chest radiograph at this point. It looks as if she's got some hyperinflation up here and some, you know, sort of irregular lung opacities. Nothing that really shouts silicosis to me, though. And this was her CT scan again from the outside, which shows a whole lot of small airway shadows here, tree and bud pattern, and pretty substantial disease here with bronchiectasis involving middle lobe and lingula. So she was told that she had a mycobacterial infection, and she rejected that, and she was sure that she had silicosis. So I spent a long time on the telephone with her, and then eventually her doctor her treating physician sent all of her medical records to me, and this imaging. I reviewed it all and declined to talk to the patient directly to tell her that I agreed with her physicians who thought she had MAI, and I didn't see any evidence of silicosis. And eventually they did culture Mycobacterium avium from her lungs. So a classic case of MAI in an older white female. So one of the standard groups to get this condition. So she doesn't have silicosis, but she has MAI, but she doesn't like that diagnosis. She wants to be legitimized in her anger against the people who busted up her tiles and create a lot of dust in her house. So I don't know, maybe she'll have silicosis in a few years, but in the meantime, she's got MAI. Okay, and then I wanted to show you this case of hypersensitivity pneumonitis. This is an earlier study from, let's see, it's from, this is 2017. Let me show you, this is 2012, so this is 5 years ago. And we have very nice mosaic attenuation. We didn't have expiration at this point, but we've got a lot of ground glass abnormality, tremendous amount of mosaic attenuation. And this fits very nicely with hypersensitivity pneumonitis. And then here's a subsequent study. Now we're up to 2017, and you can see that this has now progressed with a ton of fibrosis, a lot of which is in a peribronchial distribution. It's causing this ground glass with reticulation abnormality in the bases here. Again, not particularly peripheral, largely around large airways, so it really looks like a very nice NSIP pattern. And at this point, we do have expiration, and we document that it's not just mosaic attenuation, it is actually air trapping. So there are these black lobules in the lung that do not deflate on exhalation. So just progression of hypersensitivity pneumonitis to pretty dramatic fibrosis. Okay, those are.
Was the antigen ever discovered?
I'm sorry?
Was the potential antigen allergen ever identified?
I don't think so. Not in this case. Okay, Jeff.
Thanks. All righty, Seth.
A question while you're sending it to Seth. What institutions still do hypersensitivity like antigen panels? Because we don't even do them anymore here.
I think we've given up on them too. They don't ever help.
Right.
We do them here. We believe.
We did them in Maryland. I don't know if they do them here. All right. This was a case where a guy with a history of Marfan's and aortic dissection came in with worsening chest pain. We can see that he has his native aortic root, but then he has this ascending aortic graft, but we can see that there's not all right with the graft here, that there is this large collection next to the graft, and there's a clear defect along the inferior surface of the aorta near the anastomotic site. So here's the portion of the anastomotic site, and we can see this large pseudoaneurysm. Now, that itself is kind of interesting, but this is actually one of my first cases here. And I noticed scrolling through that there was a strange kind of line between the pseudoaneurysm that was dissecting around the graft and around the ascending aorta and the pulmonary artery. Unfortunately, we had done this retrospectively gated, and you can see that there's this flash of contrast from this fistula between the pseudoaneurysm and the main pulmonary artery. So it's kind of wild that I guess the pressures got to the point where it was so high that, and this was confirmed, they took the guy to surgery and said, in fact, there was a fistulous connection between
Awesome.
his pseudoaneurysm and the pulmonary artery.
Wow, that's good.
The surgeons thought I was crazy. They actually told me they didn't know me. They're like literally, and I was like, okay, fair enough. I understand. I would think I'm crazy too. But anyways, but it was very nice. The surgical note matched exactly what we saw. But again, I'll send this over. You can see that defect here. And he is doing really well.
Again, so we can see, is that contrast carried preferentially to the right pulmonary artery? There's
sure. Let me reset it.
So Seth, Brent showed a case almost identical to this a year ago or so, except he didn't have the 4D, but it was the same thing. It was like I think Leif was the one that suggested this is white smoke because it's a shunt. It's like it's because without that contrast, I mean, would you have ever called a hole there?
No.
Hell no.
Never. First of all, I wouldn't look that closely to look for the hole. But I mean, without contrast, I mean, how would you? Yeah, there would be no way. And we just got really lucky because I just decided to retrospectively gate it because he had a history of aortic root, and we had no idea what was going on. It just kind of turned out nice. But no, so Howard, it's kind of looking like it's directed right at the bifurcation, so it's kind of smacking against the proximal.
It's going into the proximal right? Just
exactly.
The proximal right.
Yeah,
so
exactly.
We see a relatively bright right pulmonary artery and a relatively not bright main and left, right? Am I seeing things correctly?
You know what? I totally didn't notice that. You're absolutely right. The contrast in the, I mean, I would have to measure it, but it just subjectively, it looks like the contrast in the right PA is brighter than the left. So.
And yeah, so well, I guess there's still some contrast in the SVC, but did you give them a saline? No, there's no saline chaser there, is there?
No.
I guess it's just the aortic contrast that's shunting.
Yeah, I didn't pick that up, so it looks like we start having unapacified blood. Just looking at it, preferentially going down the left. I don't know. It's a good pickup. I didn't appreciate that. It could be the saline chase. I wonder how this shunt, if at all, altered his pressures in his right PA versus his left. But anyways, that was a cool case.
Wow. And
then this was a neat case that it doesn't mean anything. I noticed this on a non-con CT. I noticed that the coronary artery ostia looked very funny, just didn't look right. And then sure enough, the guy had a coronary CTA because someone picked this up many years ago. This is a coronary CTA from here about 7 years ago. And it's a very odd configuration. There's separate origins of the circumflex and the LAD from the left sinus. They do both arise from the left sinus, but the left circumflex arises more anteriorly and crosses over the LAD, which arises more posteriorly and inferiorly. So it's just kind of this crisscross ostium of the coronaries. It doesn't mean anything whatsoever. It just was a odd configuration if I had seen one. So here you can see the circ and the circumflex and the LAD crisscrossing one another before going in their kind of normal positions. That was just a cute little thing. And this was a case just before I had left Maryland. This was a nice case of a type 2 truncus. So we can see that the left and right pulmonary artery, I was trying to determine, I would call it type 2. I don't think there's a single pulmonary trunk. I would call this probably 2 arising from the posterior lateral portions of the ascending aorta. 3 would be off to the sides. This would be a type 2 truncus, but what's cool about this, which was confirmed surgically, was that he had a quadricuspid valve as well. So we were wondering if it was quadricuspid or unicuspid, if there was just a single kind of commissure here with this, but then we saw this and it turned out it was, sure enough, it was a quadricuspid valve. So a type 2 truncus with a quadricuspid valve. And I think those were the main findings. Obviously, there's a large VSD, as you need that, and an ASD as well. But the VSD was bigger. Anyways, those are my cases.
Wow. Okay. Thanks. It's like a congenital day. Okay.
Yeah.
Travis, I have to leave just a few minutes early to get to another building.
Okay. Go ahead.
I'll just show mine quickly, and then we'll finish it from here. Okay. Let's see here. All righty. So this goes along with David's cases. I just happen to have three cases of Mycobacterium avium complex infection with 3 different manifestations. The first one is a 64-year-old man who has a radiograph. You should be able to see that looks like this. And we see a cavity and some nodules in the left upper lobe, and there may be some nodules in the left lower lobe. And on CT, we see an ugly cavity with consolidation, ground glass septal lines around it, maybe a little crazy paving, and then a little bit of stuff down the lingula and some airway-centered nodules in the left lower lobe. So my colleague Chris does upstairs, downstairs lesions. So this looks like the so-called classical appearance because it looks like typical post-primary TB. This is a different demographic, of course. This is a middle-aged man who does not have a narrow AP diameter, does not have underlying bronchiectasis. But this was all non-tuberculous mycobacterial infection and went away with treatment. I have follow-up imaging that just showed some scar in the upper lobe.
Any immune compromised, Jeff?
Nope. Otherwise healthy.
And white.
And white.
Mm-hmm.
So here's the next one. This is a patient who was a former smoker. And let me make sure it's showing my screen here. You should see a Röntgengram here. And we see what looks like a mass in the lower right lung. And you can see on the lateral, it's in the middle lobe. May have a branching configuration. So got a CT because of the abnormal finding. He presented with a cough, also middle-aged. And you can see no bronchiectasis in this area. Otherwise healthy other than a former smoker. Doesn't have much in the way of emphysema. And you see this mass out in the middle lobe that sort of branches out, and there's an airway running up to it here. And then you see some distal dilated airways. So the concern was there was an endobronchial mass and that this was going to be a lung cancer. He's got a little bit of smoking-related lung disease in the bases, maybe some mild bronchial dilation, some little bit of reticulation, maybe an aspirator. So this was needle biopsy twice and showed necrotizing granulomas. On bronch, they were able to recover MAC, so some not TB but MAC. So here it is presenting as a solitary nidus. You'll note there is a little bit of bronchiectasis here, but previously healthy before, and so not lung cancer. And then following treatment, this thing is sort of melted away. And then the third case is an 86-year-old white woman. Make sure we're showing a CT scan. I don't have a radiograph, with a more typical appearance where we see background structural lung disease of emphysema and a bunch of airway-centered nodules. You can see them with air bronchograms in the middle, a cavity or two, and then a lot in the middle lobe, lingula, and the lower lobe. So it looks like a diffuse chronic large airway and small airway involvement. And this is a much more severe case. And interestingly, in my experience, these are the patients that they never seem to successfully eradicate, probably because they have a large burden of organisms, and the older patients have a harder time tolerating the 4 or whatever drug cocktail it is, similar to some of the TB drugs. So this is a sort of a combo, non-classical and classical. And of course, these cavities get bigger and smaller and all sorts of things like that. So 3 cases of MAC. And now,
quick question. Yes. Maybe it's just semantics. Mycobacterium avium intracellulare versus complex. So, is there a difference?
Yes.
I don't know.
So, in my recent reading, Mycobacterium avium and intracellulare are 2 distinct species. But it's like nocardia. They're all grouped together in a complex, and it takes DNA probes, I believe, to separate the 2 out. So many labs don't make the distinction, especially if you culture them. So I think the preferred term in my reading of the infectious disease papers is MAC over MAI.
So and the same thing is true. There's a tuberculosis complex, which includes MTB and also M. abscessus and stuff like that. So complex means that they have enough in common that they're, unless you try to individuate the species, they're gonna come out the same on most tests, and they behave partly the same. So the complex is larger umbrella.
Okay, so this is I always forget to look at the age. This is an adult male with an incidental finding who's had a left upper lobectomy for lung cancer. And you can see a tubular structure originating from the right hilum with some lucency or rarefaction, as David said, around it. And you can see where I'm going with this. But I pulled this in here as soon as he showed his case, because this is another right upper lobe bronchial atresia in a patient who's already missing his left upper lobe. And you can see it's involving the entire apical segment, and the lung behind it is hyperinflated, hyperlucent. I did look for other anomalies, but I just, okay, I found one right here, a tiny little one. I would argue there's a tiny little CPAM right in here. There's a little bit of dysplastic lung, and this lung doesn't form normally, but no vascular anomaly to go with this one. So another bronchial atresia, just pretty typical. All right, now this is the fun one here. I got 2 fun ones, but this is, I think, the most fun one. So this is let me make sure I'm sharing the screen properly. So this is a 56 or so year old man. He presented to the ED just recently with some chest pain. And I thought it was an odd looking case. It's a sitting, alleged upright, but we all know when you see clavicles that high, it's not really upright. AP, but it's non-portable. And he had this funny interface along his mediastinum, very lucent. So I assumed it was probably fat. He's a large guy, and the paratracheal region looked fine. He had another interface over here that looked like fat as well. But I hedged my bets and said, I know they're going to get a PE study. They ended up getting an aortic dissection study, but same deal. We got some contrast in here. But what was striking, I should go back to the radiograph, is also you'll notice the trachea is midline, right aortic arch. Nothing else looks odd. What's nice on the CT is we see a couple of things. I got really excited when I looked at this. So first of all, you'll see there's a vessel to the left of the aorta, which violates one of my rules. There should never be a vertical vessel there, and it connects up to the brachiocephalic. And then there's really just some thymic veins coming down. There's no bridging mediastinal vein. So this is a duplicated SVC, and it has a nice hemiazygous arch coming into it. And the azygos and azygos don't connect. Sorry about the freight train. Hopefully you can still hear me. Follow this down, and of course it goes into this nice, juicy coronary sinus, and this ostium is intact. So we have a duplicated left SVC, but I'm not showing you a left SVC. I'm going to show you.
So Jeff,
yeah.
Is the airway look Those vessels look very symmetric around the left atrium. Is the airway?
I'm getting there, David. You're ahead of me. So here we go. We have a tracheal bronchus that supplies, okay, well, this is where it gets confusing. So there's a tracheal bronchus too. So yes, there's more than one thing going on. But what's really cool is if you look at the airways on the right. So you got the tracheal bronchus, and let me make it bigger so you guys can see a little bit better. Then you follow the trachea down, and you see the left. Now the left bronchus goes out and branches fairly normally, but the right bronchus is odd. So here's bronchus intermedius. The upper lobe came off earlier, but it's interesting because it's a small upper lobe. We see what looks like an anterior, maybe an apical, and a posterior segment, but they're small. And then the bronchus intermedius branches off. There's this anomalous branch here, which is probably the middle lobe, that seems to have maybe one segment. There's a basal trunk that gives off a superior segment, another anomalous segment, then it goes down and branches to the medial, anterior, and lateral, or some variation. The other striking thing is there's really not much in the way of fissures. There's a little bitty one here. I don't know why we don't see it so well. It's plain, but there appears to be a single fissure, or at least in part of it, and maybe a tiny little fragment of a fissure here. So I think this is a hypoplastic lung with abnormal lobation. You'll notice there's rightward displacement of the mediastinum, or shift of it because of the hypoplastic lung. No anomalous venous drainage, so it's not a scimitar, but it almost has airways reminiscent of a scimitar, and another anomaly to go with it with the left SVC. And
well, Jeff.
Yes.
Yo, Jeff.
Yeah.
I'm so excited here. It looks to me as if you remove that tracheal bronchus, then the rest of the airway is amazingly symmetrical on two sides, and I think the pulmonary artery is going over the right bronchus.
Yeah, I was just looking at that. So here's, let's see, right pulmonary artery. I don't know why I keep hitting the button. I keep pushing the wrong button here. Let's try this again. Okay, I'm going to keep my finger away from there. So if we go to 1 here, we see the pulmonary artery. There's the airway passing in front of it. And on the left, we see the airway and the pulmonary artery. So this one, the left is hyparterial. The right, I think it's, I can't make up my mind. It's hard to say.
It just looks so remarkably symmetrical.
I agree.
A sagittal reformatting would be cool.
Okay, I can make that in a second. Push this button.
I think that's why there's fissurepenia on the right too. There may be just a left lung pattern of two lobes.
All right, let's see what we can see here. So we follow it back. So there's the aorta, so we're on the left.
Okay, and here's the pulmonary artery going over its bronchus.
Yeah, so it's a hyparterial bronchus as we'd expect. Now if we go over to the right, branches right before it there. So I guess it's technically hyparterial, huh?
Yeah, if you take out that tracheal bronchus. Yeah.
Cool.
So I think you have left lung isomerism too, and that's why you have a left SVC.
Yeah.
This has a lot of leftiness. Is the abdomen okay?
Yeah, no spleen. I mean, one spleen, no azygous continuation, no midline liver. Just a metabolic syndrome that goes along with that mediastinal fat. And just to, and the final thing is all the fat here in the anterior mediastinum. This is what accounted for. Just ignore my phone. All right. And then the last case I have real quickly is a fun one. Let me pull it up here. So this is a guy who, let's make sure you're seeing everything, get the right scan, who had a lung cancer back in the 90s, way back when. And he actually, when they resected it, found out it was actually a colon primary. I got to find the old radiographs here. It was a colon primary. So he had ended up having a resection for that, recurred, and ended up having completion pneumonectomy. He's been cancer-free since, but his pneumonectomy space got infected. And so he ended up with an LOS or flap. And here's his radiograph. You can see there's the chest wall defect, pneumonectomy cavity communicating with the outside world. And he's had this for years, and it's slowly been healing, and recently presented not feeling so well and complained of some excessive drainage from the LOSer. flap describing things that he drank coming out into the pleural space. So let's see what I can show you. Let me start with, did I grab the wrong esophagram? Yeah, I grabbed the wrong esophagram, but here is a static image from it. And you can see there's barium, or oral contrast here, in the pleural space. So he has an esophagopleural cutaneous fistula. And here's a CT, a recent CT that shows that defect right. We see this is right where it is here. There's this, yeah, right there. So this is 2 decades or so later as a complication. And actually, they have now closed this up. They brought in a bunch of muscles to finally seal this thing up, let this cool off. They covered it up, and he's doing well. So, this is, we don't see these all that often, but this is a definitive treatment for a chronically infected pleural space. There's also a Claggett window, and I've always tried to sort out the difference, and they're pretty much the same thing. But what happens is that you can see this even epithelialized with skin. And the thought is you just slowly let it fill in. They put packing in. They can get fistulas with the airway. They can get but this is the first time I've seen a fistula with the esophagus. And so the barium, I'll have to dig out the swallow that goes with it. This may be it here. Yeah, I think this is it. I was just looking at the wrong date. Yeah, you can see it right there. As it goes down, the contrast is pooling in, right, flowing right in there. There it goes. It's the next swallow, and you can actually follow it right into the pleural space. So,
wow.
I think it would be, you could just, honestly, you could test it with a colored liquid. You wouldn't even need an imaging study, but it nicely showed it. Okay, those are my cases. I'll turn it over to Travis, and I'll stay on till about 5 till, and then I will let Travis wind it up.
And then if I just close GoToMeeting at the end, it'll stop the recording.
It'll shut it down, and it'll stop recording, and everything will be all good.
Okay. All right, do you see my screen?
I do.
So this one is in honor of Howard's case of the midline nut carcinoma. This is one that we recently saw. Now, this is a lady who has melanoma, and this was 2015, and she was found to have this little thing right here. This is not, just for the record, this is not a midline nut carcinoma, but it's an obscure tumor. So at this time, you see this thing doesn't really look like a melanoma metastasis. It had been growing slowly, and she hadn't been on any sort of chemotherapy. So it's not like it's met that had become necrotic and cavitated or excavated. Came back in 2017. We said we thought it was probably going to be a small adenocarcinoma. Gets a little bit bigger. Certainly, there's a little bit more soft tissue around it. And this was one of these cases where we recommended this thing just go straight into a bucket. It was discussed at tumor board. She didn't want to go under surgery, so we ended up, push comes to shove, we ended up doing a biopsy of this thing. And you'll see there it is. And, well, one of these shows that we actually got into it. Yeah, we're into that thing there. And the FNA cytology came back as adenocarcinoma, and well differentiated. They took her to surgery, and this was within the last month. And the final path came back as a ciliated muconodular papillary tumor of the lung, which was a real head scratcher at tumor board. Nobody except the pathologist had ever heard of this, but apparently it's a pretty benign tumor. I don't know if anybody's ever seen one of these, Seth, or anyone, nope. But nope. Just one of these weird ones. And again, why I think that our decision to just do a CT guided biopsy in the first place was an unnecessary step, but well, so kind of interesting. So as you can see here, it's just some rare tumor that has a pretty benign course.
Ciliated muconodular.
Yeah, right, not micronodular, but muconodular. So, and that's why I think with the limited cells that they got on the FNA, they thought it was probably a well-differentiated adenocarcinoma. I included that as in the report as well. So another one of these ones you're never going to diagnose prospectively, but kind of interesting when you do see it. And good news for her, it has a good prognosis. Now, Jeff, hopefully you'll be able to stay on for this one. I showed this case before they did anything with it. I think I showed it maybe as a consult. And this is a woman who's in her 30s now, and she has Vacteral syndrome. She had a prior TE fistula repair. As you can see, she has vertebral anomalies, probably a hemivertebral, like a hemi-butterfly vertebra here. And I'll show you her lungs aren't that normal either. But now she's presenting with dysphagia, swallowing difficulty. And you can see on her outside swallow study, her proximal esophagus is very dilated, and her right here, mid-esophageal level, there looks like there's an extrinsic compression. She underwent an EGD, and they found a pulsatile mass at around this level. Ended up at some point undergoing the CT. I don't know. This was all done at an outside hospital, and was referred to us because the diagnosis was that she had an dysphagia lusoria from an aberrant right subclavian artery. You can see that she does have a left arch, and she does have an aberrant right subclavian artery, except that's pretty high up, and it's really not exerting any mass effect. But then what's interesting is her aorta crosses right at the level where the compression occurs and descends then on the right side. So this is really, this was, when I was reviewing at the surgical conference, I said I thought this was a circumflex arch. That's by definition, it's a left arch, it descends on the right side. So that by definition is a circumflex aortic arch. And the surgeon agreed. We thought that probably the compression was from the arch itself rather than the aberrant subclavian artery. Now, before I get to the treatment, it is interesting to note that I told them that she has just a single lobed right lung that really only has, I don't even know what these, what you want to call these different branches, because she really doesn't have much in the way of normal branching, I would argue. But anyway, this is all just related to her multiple abnormalities of her Vacteral syndrome.
How do you spell this syndrome, please?
VACTERL. It's one of these acronyms. It's vertebral anomalies, anal atresia, cardiac, TE fistula, renal, and limb.
Limb. So what are they going to do for her, Travis? Because you can't. You can't really resect the aorta.
Actually, I'm glad you asked. It's like I planted that question. Yeah, they actually do. They do what's called an aortic uncrossing.
An aortic uncrossing.
Right. So they go in, and of course everybody in the congenital conference, their interest peaked up when the surgeon was saying he was going to go in and resect the aorta and basically transpose it. So you can see now this is post-operative. She has a right aortic arch instead of a left aortic arch, and this is actually with a graft. And now this is a surgery that I had read about. And Carl Backer is in Chicago and writes about all of these surgeries. But basically, you ligate the descending aorta and you transpose it to the ascending aorta here. Now, in this case, they had to use a graft to complete it, and it's obviously the opposite because it was a left arch that they moved to the right. But actually, yeah, but this is what they do. They literally ligate it and reimplant it. So they uncross it, and I included the description of the surgical procedure. Come on, my screen is freezing up. Let's see here. Here we go. Yeah, it's pretty lengthy, but he talks about uncrossing his aorta. So it's the first one of these I've actually seen. It was kind of exciting to see that.
Very cool.
And of course, all the questions came up, well, like, is she going to have paralysis and stuff from spinal arteries? And the conclusion is no. She has intercostals, which they are able to mobilize without necessarily ligating all of them.